All right, so we'll start from where we left off, which I think was stroke here, because I do kind of remember the last thing we went over were the concussion injuries. That was right at the end of class, so um, concussion injuries do not mimic typical neurodegenerative diseases when you're looking at neuroimaging data. So they might present sort of like it. They might kind of present like, say, a Parkinson's style disease. However, one of the slides shows the progression of Alzheimer's, which is what I meant, not Parkinson's, Alzheimer's. They might present like Alzheimer's, but if you look at the neuroimaging data, you can actually see that they affect different parts of the brain at different times, and the progression is different for Alzheimer's versus multiple concussion injuries. So on the surface, it might look like Alzheimer's. A multiple concussion injury might look like Alzheimer's, but if you're tracking progression with um, imaging, it won't look the same. So they don't mimic in the actual progression of the disease, but from outside they might. Okay, stroke. So ischemic versus hemorrhagic. This is a pretty easy question. Hemorrhagic, right? Like a hemorrhage, a vessel will actually burst, right? And there will be actually like blood in the inside the cranial cavity, right? So the blood flow is not getting where it needs to because it's it's open, it's coming out, right? Ischemic is that there is a blockage of some sort. It could be a blood clot. It could be swelling is pushing on a vessel. But either way, there's a blockage with ischemic, and there's like an open bleeding wound with a hemorrhagic type stroke. In either case, blood doesn't get to where it needs to. And I forget if this is the class that I talked about this in, or if it was in my 310 class, but while we can go a long time without oxygen, the brain cannot go a long time without oxygenated blood, right? So we're looking at 30 seconds, a minute. This is causing severe damage, right? And the reason why we can be deprived of air for that long or more, I mean, some people can't, they'll be under for a little while and they'll have brain damage. Other people with larger lung capacities might be underwater for 3 minutes. Some people, you hear about them being underwater and, kind of drowning for 5 to 8 minutes and they're pulled out and they're okay. That's different because you still have air that was in the lungs. There's still blood that can be moved around the system to be reoxygenated and get back to the brain. So that's different than actual oxygenated blood making it to an area of the brain. So when you have an occlusion right on the brain, that is an acute problem. It's not something that can wait. I mean, seconds is damaging. All right. What is spontaneous recovery? Well, spontaneous recovery is kind of what it sounds like. People will spontaneously recover once they've had these strokes. So when let's say the day after, they wake up in the hospital and they're pretty bad. They may have symptoms of aphasia. They may have really exaggerated symptoms of stroke, a lot of facial drooping, paralysis, stuff like that. But if you remember, these aren't treated right away because of spontaneous recovery. So there is like an acute problem that happens with a stroke, and it is unsure how much of that acute problem will resolve itself. Could be the whole thing. Some people have stroke related issues, and in a few days they're almost back to normal. A little bit of weakness, but they could be okay. Some people might retain some of those problems, like paralysis or aphasia. So do aphasias only impact speaking? No, they don't. Writing, signing, and speaking are all impacted. It's something more higher up in the language communication area that gets impacted. So it's not just making an idea become verbalized. It's actually getting the idea from somewhere in the brain into where it can actually be used in language. One factor that's used to determine severity is fluency. How fluent is someone? Um, I don't remember if Dr. Rogalski went over this, but anomic aphasia kind of mimics a tip of the tongue state, which is, if you don't know what tip of the tongue is, it's when there's a word and you know it, but you just can't think of it right at that point. And I mean, this sounds a little bit like Broca's aphasia, probably. And so you'd be probably not surprised to know that anomic aphasia and Broca's aphasia are similar. So anomic aphasics, they're not as severe as people with Broca's aphasia. You remember Broca's aphasia, one of the videos we watched, the guy was trying to say ladder, and all he could say was like zoom, right? And it just wouldn't come out. But there was a lot of other problems with that too, right? So like while he was trying to say what ladder was, there were other problems with speech that, and he's just like, it just won't come out. Anomic aphasia is you're a lot more fluent, but you're kind of always in this like tip of the tongue state with some words. So fluency is one major factor used to determine severity. Well, we talked about Broca's aphasia, but Wernicke's aphasia is one that's more a little bit word salady, right? So this is the video of the guy who was on the cruise for aphasia patients, and he just seemed happy. He didn't seem to know that he was saying just jargony, nothing phrases. They're over there, and them very happy for them is one of the things that he would say, right? And it sounds at the very basic level like it might actually be like real, totally fine speech. When you listen to what the words actually are and how those words are being used to respond to a question, it's not very, it doesn't fit, right? It doesn't fit any of the rules that we would expect. It's completely non sequitur. The actual fluency of that speech, though, is pretty good. So it's sometimes referred to as fluent aphasia. Wernicke's is also referred to as fluent aphasia. Broca's non-fluent aphasia. The goal of aphasia treatments for you as an SLP would be, you're not going to cure aphasia, but what you might be able to do, especially with people with Broca's or anomic, is teach them certain words that they want to know. So you want to make it easier for them to communicate in whatever way they can handle, whatever works, right? And so you'll try to communicate with them and figure out what words are the ones you want to focus on. Remember, there was someone who really wanted to be able to say their dog's name. There's a lot of people that want to be able to say their spouse's name or their children's name. So, and then use, you might want to teach them other words for important communication as well. So that's the goal of treatment. All right. Anatomy, what's the major muscle of breathing? It's the diaphragm, which is kind of this like parachute-shaped thing, parachute-shaped muscle that attaches to various places all around the inside of your thoracic cavity. It's got a tendon in the very middle of it, and all of the muscles of the diaphragm are going to pull down. So they're going to pull, they pull it downwards, the muscles contract and they pull the diaphragm down, and then they're pulling against that central tendon that pull it down. When that's pulled down, the increased space inside the thoracic cavity has a pressure change which allows the lungs to grow to expand it. When the lungs grow, allows the lungs to expand to fill that cavity, I should say. When the lungs expand to fill that cavity, air will rush in to fill the lungs. And that's when the gas exchange actually occurs. Okay, so forces of exhalation, there's two types. So one is just relaxed exhalation. And in that case, it's all passive. Gravity is just going to pull down on your rib cage, and also you've got elastic forces of the thoracic cavity that are going to come back together. The diaphragm muscles are not tensed anymore, so they're going to release. So all of this just kind of passive stuff happens to cause exhalation. But there's also forced expiration or forced exhalation, which is going to, it's what you use when you're actually speaking. The abdominal muscles are going to be a large player in that, and also the internal intercostals, which are between your ribs. For forced inhalation, obviously you use the diaphragm, but you're also going to use the external intercostals, in addition to a few muscles up in this area that'll help lift the rib cage. All right, how does sound leave the larynx? Well, it passes between the vocal folds, and they're going to be in an adducted position, so they're going to be kind of like this between my two pinky fingers here. And the sound is going to move between those. And when it moves between those, they're going to kind of flap back and forth together, and it's going to create this pulse of air. And this leaves as a sound pressure wave, or which would be sound. All sound that travels through any medium, air or water or anything, is a sound pressure wave. And so essentially the sound is leaving the larynx as a sound pressure wave. You can also think of it as a buzz, right? So just a buzzing sound. So it's either a sound pressure wave or a buzz. The three main cartilages of the larynx are the thyroid cartilage, the cricoid cartilage, and the arytenoid cartilages. There's more, but for this class, that's really all we need to focus on. So the main functions of muscles on the vocal folds are going to be that I totally lost my train of thought. So the thyroid cartilage and the cricoid cartilage sit together kind of like this. So the cricoid cartilage is a ring, and the thyroid cartilage is just kind of a plate that sits on top of it. So the thyroid cartilage will rock forward. So this over here is the front part of the person, the anterior part of the person. So this will rock forward, and that's going to pull on the vocal cords, the vocal folds. When you tighten the vocal folds or pull them, extend them, make them longer, that's going to be a higher pitch. So that's one main function. The other one is going to be adducting and abducting the vocal folds. So what's going to happen is the arytenoid cartilage, this is the cricoid cartilage again. You've got arytenoid cartilages that sit right here, and they're going to swivel, and when they turn this way, they're going to bring the vocal folds together. When they turn the other way, they're going to bring the vocal folds apart. When they bring them together, that's adducting, ADD. So think of that like adding together. And then when they go the other way and the vocal folds are open, that's abducting. Think about that like aliens are abducting things, cows, whatever. So adducting, abducting. Where are we? How does resonation work? So resonation is going to be that the different shapes of different cavities of the pharynx and the mouth and the nasal cavity, they're going to have different resonant frequencies, so different frequencies that they like to accentuate or dampen based on their shape and configuration. That shape and configuration can change, and that is what creates the difference in vowels. So remember that video of a buzzing like vocal fold is what it was supposed to be replicating. And they put that tube on it, and the tube replicated the configuration for an ah, and that made it sound like an ah. So that's essentially what we're doing in here is we're configuring all of these different cavities in a way that makes something sound like an ah, or an e, or an o, or an oo, or any of these vowel sounds. That's how vowels are related to resonance. So different resonant frequencies will be accentuated, other frequencies will be dampened based on different configurations of the mouth, nasal cavity, and pharynx. And then consonants, different places where you're going to put stops are going to create consonants, right? So you've got dental labial, right? Like F. You've got palatal consonants as well. Well, actually, I guess I should do like you've got alveolar dental, right? So you've got different things like that. All these different consonants. So different places in the mouth where you'll put constriction will give rise to different consonants. And it can be all the way back to a glottal stop like uh-oh or button. All right. So speech sound disorders, this one, like I say on here, there was a lot of stuff that was a little bit of review. But 90% of cases in primary grades are going to be articulatory problems. The second one is not a question, it's just a statement that articulation disorders are interactions of timing, direction, pressure, speed, and integration of all those things. That's what creates an articulation disorder. The FOXP2 gene is related to speech sound disorders. If you remember, it's the KE family in the UK that has this FOXP2 gene. And FOXP2 is associated with delayed onset of speaking, a lot of slurring, trouble articulating, things like that. So FOXP2 is a genetic link of a speech sound disorder. Things that you'll be looking for in your oral mechanism exam, you're going to be looking for making sure the articulators all look good. You'll look at the range of motion, the strength of the muscles. Let's see, what else do I have written down here? Coordination between them and rate of movement. Those are other things. What do the edges of the sound development chart correspond to? Do you remember? I'm talking about like percentages here. Well, first of all, do you remember what the sound development chart is? So the sound development chart is, it shows you like the age range that children should have certain sounds. The left, well, that's not going to be right for you watching, but anyway, the left-hand side is 50% of children when they have a handle on that sound. The right-hand side is 90%. For the stages of treatment, you're going to start with teaching your client, usually a child, but it doesn't have to be a child, right? You'll start with a sound in isolation. Then you're going to want to move to putting that sound into words and then phrases. And then you want to have them read. And then you're going to move on to conversation. That's the most tricky one, is conversation, because they're actually thinking about something that they want to talk about. And so it's kind of like now they have to have learned the speech sound enough to be able to do it really without thinking about it. So they've truly learned and mastered it by the time they can do it in conversation. So isolation, in words, in phrases, reading, and ending up with conversation. Okay, so vocal play is going to be just using, making consonant sounds. There's also a lot of gurgles and growls and stuff in there. So it's just kind of when babies are trying to figure out all the different possible things that they can do with their mouth, with their vocal folds, all this kind of stuff, right? So there's a lot of like change of the fundamental frequency of the voice, right? So really high down to really low, and just kind of playing with things and like babbling. The jargon stage is a really good video that I just put on Canvas. And the jargon stage is when a baby or toddler is trying to emulate the people that they're around. So they'll kind of say things that almost sound like the right language. They don't have the words down yet, but they've got the gestures, they've got something that sounds like the words. They're putting together like blah, 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 blah. And they're using intonation and things like that. So they're trying to speak just like everybody else is, but they haven't quite learned the words yet. Okay, so consonant vowel and consonant vowel consonant words are the first ones that will emerge. And more complex words usually get shortened a little bit, right? So you'll have final consonant deletions. You'll have some areas where you might just kind of drop entire halves of words, right? So tra instead of truck. You might have some substitutions for a speech sound that the child has already, but with a sound that they don't know yet. So remember, fronting is much more common and typical. Backing is not typical, so they might be fronting things. Cluster reduction and unstressed syllable deletion, these are other things that might happen with longer and more complex words. So cluster reduction is when you have a string of consonants. So, well, with the word string, S-T-R, they might say sting or ting, something like that, right? So they're going to drop some of those clusters and reduce the cluster to something more manageable and more understandable. Unstressed syllable deletion is they're going to, you know, like we talked about, they're going to drop the unstressed syllable to make it something more like a consonant vowel or consonant vowel consonant word. What is a fricative? I'm going to let you figure these out. Just go and look at this part of the lecture. Which sounds are fricatives? And which sounds are liquids? There's only two of the last one. So no fricatives and no liquids. But check that out on your own. Okay, is regular speech fluent? Is it 100% fluent? I'm going to let you answer that on your own as well. What is a disfluency? It's anything that interrupts the flow of speech, right? So an or a restart or a slight stutter on a word, any of those can be disfluencies, right? The primary symptoms of stuttering are blocks, where the person is not going to be able to get sound out, right? So that's a block where it's silent for a long time. It's usually a tense silence because they're trying to get it out. When the sound finally comes out, it's usually a lot louder than intended. Another one is going to be repetition of the first syllable or sound. Soda was one that we had. And the last one is going to be sound elongations, which is kind of like a repetition, except that you're not repeating it. You're just dragging it out, right? So you might see. Well, so the soda one could be soda, but it also could be soda, like that. So those are three primary symptoms: blocks, elongations, repetitions. Secondary symptoms, these are interesting. These are a little bit more common, they're not, like it says, they're not the primary symptom, right? There's something that is done to try to compensate for the primary symptom. So something like shaking the head it almost seems like it's trying to knock the sound loose, pounding the fist, shutting the eyes very tightly. A lot of tension in the neck and the articulators is common as well. So these are all secondary symptoms. Stamping the foot is another one. Developmental versus acquired stuttering. Developmental is, it's part of the developing process of speech, so it shows up in a child, and that's a developmental stuttering. Acquired would be something like, caused by brain damage or TBI or stroke. And then now you have induced stuttering at a later stage in life than you would typically see developmental stuttering. Stuttering is worse when there's anxiety placed on top of, somebody who's already stuttering, and then there's anxiety. So talking to an authority figure, giving a, public speech, there's going to be anxiety in any of these settings. And so there's going to be more occurrence of stuttering in these occasions. Also with more complex words, that as well. It's alleviated a lot of times when people who are stutterers sing. They don't seem to have problems stuttering, and then also possibly when they're using different voices, accents, and things like that. Some people report having their stuttering alleviated. So Broca's area seems to be less active in people who are stutterers. There's some genetic evidence. Twins are more likely to, well, I should say, identical twins are more likely to both be stutterers than fraternal twins, so it seems like there's a genetic link there. The relation to Parkinson's is a little bit of a long relationship, but essentially, remember, it's possible that stuttering is related to deficits in the basal ganglia. The basal ganglia deficit might be related to dopamine. And so then you'd actually see that people who take Parkinson's medication to alleviate the symptoms of their Parkinson's may have problems with stuttering, because they both function on dopamine, but they function the opposite way. So Parkinson's is low dopamine. It seems like stuttering might be increased amounts of dopamine. People who are stutterers usually have decreased reaction times, and this is overall. So this is that PVT that I had you guys do, like the time that it would take to hit the button once you saw something counting up. It's just a motor behavior, but it seems like stutterers are a little bit slower with reaction time. Voice onset time, they're also slower to start speaking. So if we did something that was like the PVT, but you were supposed to say stop instead of clicking a button, you would see that people who are stutterers would start speaking later than people who are not stutterers. Timing seems to alleviate some effects of stuttering as well. So if you can talk along with a metronome, the stuttering in a lot of people seems to disappear. Other fluency disorders, spasmodic dysphonia is one, which is where the vocal folds are kind of spasming, so they might be adducted, and then, so you want to be adducted partially when you're speaking. They're pretty close together, they're touching, but they can be easily blown apart by air. But you don't want to go into full adduction, because then that's holding your breath. So spasmodic dysphonia can cause them to come together or come apart, and it'll create this wavering, unsteady perception of voice. Using one of those vibrating tracheal boxes instead of an actual, I should say, laryngeal, vibrating laryngeal boxes to create speech instead of the vocal folds, because you've had a laryngectomy. And cluttering, if you remember, cluttering It's almost the opposite of stuttering, but it's like falling over the speech sounds towards the end of a statement. Um, and then also, I think I listed the acquired stuttering on there as well, because it kind of seems like acquired stuttering and developmental stuttering might be slightly different, but maybe not if it's damage to the same part of the brain. So if we're thinking about basal ganglia, it could be that TBI damages basal ganglia, and some people are born with slightly subactive basal ganglia, so it might be somewhat similar. All right, I think I'm starting to lose my voice. The source filter model is where you're going to have two sources. You're going to have a power source, which is your breath. That's the power that's pushing it out. You're going to have a source of phonation, which is your larynx. And then the filter is just the pharynx, the oral cavity, the nasal cavity, and the articulators. And those are going to filter the sound into recognizable phonemes. How many vowels are there in English? This is one. Now I'll tell you this one. So there's either 15 or 16 depending on who's counting. So the accepted number is sometimes 15, sometimes 16. Cleft lip and palate. So you should know the different types of clefts. That's one I'll let you guys look at too. But remember, there were if it's just a cleft lip or it's a full cleft, different things like that. Look that up, know those. The submucosal cleft palate, that's the one that looks okay, but actually it's the child who has the submucosal cleft palate is missing the bony structure and the muscles that are necessary to create suction and to give you a hard surface to be able to articulate against. So it looks okay. If you'd looked in and did like the visual examination, you would think, no, they don't have a cleft palate, but they're lacking a lot of the structure that is necessary. So diagnosis rates. So diagnosis rates, what I'm really looking for are those interesting numbers that we saw between men and women. Right, and so one of the things was that for cleft palate only, it's more prevalent in females, and the ratio is almost 2 to 1. And then for cleft lip, that's actually more present in males, 2 to 1. So that's interesting. What things contribute to cleft palate? Well, smoking does. Also, there's some just genetic factors that do. And there was also a morning sickness medication that was popular in the well, not popular, but it was used in the 70s that also contributed to cleft palate. Speech errors that are common with clefts, those are going to be placing errors. So the people with cleft palate will do a lot more backing because they don't have this top hard palate to articulate against, which I've said, but they'll move it back and sometimes go a little bit more glottal or velopharyngeal, right? So you have a lot of G's and K's. Airflow is going to come out through the nose, right? A lot more nasal airflow than there should be. And then also they're not able to generate, because of that airflow, they're not able to generate the pressure that they should be able to for buzz and puzz and things like that. And then the last one, again, is another statement, but when you're seeing a patient who has cleft palate, you want to make sure that they have a craniofacial team, well, that the parents have a craniofacial team when you're, an SLP. All right, so dissonant sounds, this is my zombie talk that I gave you guys. What's the difference between a consonant and a dissonant sound? Well, a consonant sound has regularly spaced harmonics, and also deep valleys. So you've got harmonics here, and there's not a lot of extraneous sounds that are doing anything between those harmonics. So very well recognizable harmonic peaks, and then these deep valleys between the different those harmonics. A dissonant sound is going to have not evenly spaced harmonics, so maybe something more like that. And then also the valleys aren't going to be as deep because there's a lot of off harmonic noise inside that signal. So it sounds just generally less clean. Consonant sounds are easier to localize, and probably that's because we have learned there's a lot of information contained in consonant sounds. It's a natural regularity that when, let's say, a 100 hertz and 200 hertz and 300 hertz partial bounce off a wall, they'll bounce at slightly different rates. You might get them at slightly different times or at slightly different phases as well. It's okay if you don't follow the phase of the sound, it's fine. But we will pick up on that reliably. It's the same. Most sounds in nature tend to be consonant or mostly consonant. We got a lot of exposure to those sounds. So we know the way that consonant sounds reach our ear. Dissonant sounds, though, they don't usually, they don't propagate very well because they're kind of like fighting with each other. The different harmonics are fighting with each other, which makes them dampen out quicker. So we don't hear a lot of dissonant sounds, and it is possible that we've learned how consonant sounds function. We don't really know how dissonant sounds function. And so because of that, we're not sure how to localize them. That's a totally different thing that we haven't learned through the course of our lives, our hearing lives, right? All right, so voice disorders. What professions are at risk for voice disorders? Teachers, singers, professional motivational speakers, anybody that does a lot of talking. A psychogenic cause would be something that is, related to some sort of psychological disorder, though this was important to note in the lecture that a lot of times people are told that there's a psychogenic cause, but actually it's just because no one is, doing a good visualization of the vocal cords and taking a listen to what the voice actually sounds like. So it kind of requires sometimes the specialized skills of an SLP to be able to recognize what's actually going on with the voice. But a true psychogenic cause would be one that is related to a psychological factor. The Voice Handicap Index can help identify the underlying cause of the voice disorder. Is it a muscular deficit? Is it a breathing deficit? Etc. So that's what the Voice Handicap Index is going to help identify. Is it an emotional problem? Some of the tests of voicing is just, voicing time of voicing. That's the ah. And then we've also got the S and the Z. One is going to be phonated. The Z is going to be Z. There's some phonation going on versus the S, which is not voiced. The ratio should be the same. It shouldn't really eat up a whole bunch more air to voice the Z than it does to not voice the S. So the ratio should be 1 to 1, or close. If it's not, that could indicate a problem. Specifically, if the Z has a much lower ratio. So if the ratio overall is higher, right? So if the S is 30 seconds and the Z is 15 seconds, then you've got a ratio of 2 to 1. And so a higher ratio would indicate that there's possibly some sort of vocal problem going on. Some things to note about vocal folds during an assessment is the color, the movement, and movement both in terms of like how are they able to adduct and abduct, the movement when voicing is happening, so what does it actually look like when the vocal folds are moving? Is one paralyzed? Is one moving not as much as it should? Remember the one that had the hemorrhage was kind of swollen, so it wasn't able to move as much. Occlusion from, say, the false vocal folds, swelling? Are there nodules or other bodies on the vocal folds? These are all things to look at during an assessment. And then nodules, also known as nodes and polyps, are growths that'll actually be on the inner surface of the medial surface, I should say, of the vocal folds that can occlude the vocal folds from making contact with each other. So if there's vocal nodules, it might prevent complete closure of the vocal folds, which would cause probably a weaker voice, maybe a little scratchier voice, but definitely a vocal issue. So those are nodules. All right. That's it. Email me with your questions. Email me or Amy or Kristen with your questions. We'll answer them for you within reason. And then I'll see you on Monday for the test. By the way, really quickly, if you study what is on this, also know the stuff that we talked about today, that Dr. Peter talked about today. But that's much more recent, so you won't have as much trouble remembering that. If you know what's on this PDF, you're good. I'm not going to pull things from anywhere else, aside from, maybe some extra credit questions might come from crazy places. But everything you need to know is on here. If you can answer all these questions, you should do pretty well on the exam. All right. Good luck.